Welcome to the National Cannabis Prevention and Information Centre's first clinically focused webinar. My name's Dion, I'm a research officer here in the clinical training team, and I'll be introducing you to today's presenter. I'll also be moderating the question time at the end of the presentation, so please type through any questions you'd like answered by the presenter, and I'll do my best to make sure that these are addressed. If we don't have time, we can definitely address these on Wednesday during our second webinar. This webinar and the subsequent 3 webinars over the next fortnight will introduce viewers to the Adolescent Cannabis Checkup, or ACCU, which is a brief intervention consisting of an assessment and feedback session. We'll break the intervention up in the following way. This week we'll introduce the first session, the assessment, so that will be today and on Wednesday, and then next week we will introduce the feedback session, which is also on a Monday and a Wednesday. This webinar series will be delivered by Etty Massillon. Etty is the clinical training manager here at NICPIC and has over 26 years of clinical experience working as a psychologist in the alcohol and other drug field. And she's been disseminating clinical workshops for NICPIC since we started back in 2007. Etty, I'll hand it over to you.
Oh, thank you, Dee, and good afternoon, everybody. I hope everyone can hear me properly. So I will begin. This is what I look like in the event that no one has seen me deliver this workshop previously. So hi and welcome. Now today, basically I'm going to outline the background and the description of the ACCU, or the checkup. I'll very quickly try to go over some slides, just give you some stats, and I guess why people use cannabis, or particularly young people, and then hopefully we can begin with the content of the ACCU. Now, I believe that Dion asked all the participants this morning, or the viewers, to print off a copy that he sent to them. So the copy that you received is doesn't have anything written on it, but I hope that tomorrow I will send you another copy that is filled out, and I'll explain why a little bit later. But before we begin, I just need to highlight a few things. This is what our this is what our previous website looked like, and hopefully you're familiar with it. Now we have a new website, and this is what it looks like. It's all very shushy and very trendy, and hopefully user-friendly, or at least more user-friendly than the last one. The search engine is this little, I guess, magnifier over here on the right-hand side. All I want to say is be patient. It's just in the process of being uploaded. It will be up soon. We're just doing an audit, and it will definitely be up within the next 2 weeks. So the entire content that was there before will be up within the next 2 weeks. Now, you can still order resources at the moment that hopefully you're all familiar with, except for people who use Internet Explorer. We've got a problem with Internet Explorer at the moment, but if you've got another search engine, you can certainly use that to order any of our resources that you're familiar with. So hopefully that should be okay. All right. Just one other thing. For some of you who may not be aware, this is one of the first things that we did as NICPIC about 5, 6 years ago. We produced these clinical guidelines, and the ACCU is discussed in there together with lots of other things. I'm just pointing this out because it is a valuable resource. It's a really good reference book. Hopefully we will do a second edition, but in the meantime you can certainly download it, print it off, and have it there for you to refer to. I was told that we've got a different URL, and so it used to be on this slide, but you'll now need to kind of look for it under the resources. But that's basically what the cover looks like. All right. So let's begin at the beginning. I guess to start at the beginning, given that cannabis use is associated with significant harms, A, and B, that young people are more likely to use cannabis together with tobacco and or alcohol, specific cannabis interventions were needed. And we realised this some 10 years ago. And the way I think of cannabis is like the BHP of drugs. It's kind of the quiet achiever. It very quietly and slowly grows on people, pardon the pun, due to its kind of 40-year-long reputation that goes back to the 60s and 70s. People still think that it's a benign drug. So there are few people, or very few young people, who would admit that it's a problem. And we certainly now know unequivocally that it is a drug of dependence and it is a harmful drug. So we now know differently. So to get started, we looked at a feasibility study. We thought, okay, what's happening in the cannabis world? The first thing we wanted to know was it possible for young people, through concerned others, to be referred into treatment? And B, does a 2-session, very brief intervention in those days have any relationship, or, does it actually get young people to lower their cannabis use? And so we thought about a 2-session intervention based on motivational interviewing. So that's where we ran the pilot some years ago. Now, this journal article is about the randomised controlled trial, which we did after the pilot. I'm going to talk about the pilot and what we found, and then I'll talk about the randomised controlled trial that we did after that. But the journal article on the trial can be found, and that's what it looks like in the Journal of Substance Abuse Treatment. The other thing that you might want to have a look at is the technical report on which this was based, and you can find that in the NDARC website. So back to the feasibility study. We wanted, as I said, to see whether young people, through teachers or parents or any concerned other, would come to see us to talk about their cannabis use, and after speaking to us, did they reduce their cannabis use? And so the eligibility criteria, as you can see there, is 14 to 19. They had to have used cannabis within the last 30 days, and I think we were very generous in terms of illicit drugs, and we were also very generous in relation to what they could drink, and we requested that they weren't in treatment within the last 3 months, and that they didn't have any psychiatric or cognitive impairment, and that they were fluent in English, because there is a requirement that you fill in some material, and so there is a requirement that you can read and understand questions. So that was the criteria, and so we recruited, or we spoke to 300 individuals who made contact. Now, I really can't remember how we recruited for the feasibility study, to be honest, but you'd have to go to the study and read up on that. As you can see, quite a few completed the screener. A lot were eligible to participate. We got them through 62 concerned others, and we had 73 young people participate. And as you can see there, they used quite a lot. They used, almost 22 days out of the last 30, so that's almost every day. 14% were daily users, so already that was a really good capture for us. 69% obtained their supply from friends or people that they knew, so I guess the other 30%, or 27%, got it from a dealer. 3% grew their own, but amazingly, which I think is good really, 58% of those who we spoke to had tried to reduce or quit, which is interesting, I think, in and of itself. So it's not that young people are bereft of kind of insight into the fact that perhaps they shouldn't be smoking. And this is what it looked like. Now, the range was from 14 years of age to 19, but the mean age was 16. Now, I think that's pretty young. Most of them were males, and and they were busy. It's not like they were sitting around doing nothing. 55% were at school or doing a trade, and 58% were employed. So that was a good thing. And of course, no surprise there, but most of them were living at home. Again, no surprise for that population, I guess, that age group. So pre-treatment, and I think it's pretty young. The mean age of first cannabis use was 13 years of age. And as you can see, one of them was 9 years old. And then within a very short period of time, some of them, within 2 years, became daily users of cannabis by 15. And then, again, looking further down, over the last 90 days, they only smoked almost 60 days. So, not every day. So not all of them were daily users. But they smoked on average, and again, there's a very big range, as you can see, 1 to 167 a day. But it kind of sort of averaged out at about 5 per day, or maybe 2 or 3 every second day. But the hours that they were stoned is exactly as we expected. 4 hours a day they were stoned. Now, the cost for them was around $50, which is not a lot. And I suspect that's probably because they got a lot from friends, and some of them grew their own, but they got a lot from friends and acquaintances, not necessarily from a dealer. So, because that $50 is a little bit cheap. But then again, that was a while ago. Okay, so at follow-up, and again, this was very good for very good data. Voluntarily stopped or reduced in the last 90 days. 77% had done that, and amazingly, 9 of them had been totally abstinent. So we thought that was great. Now, we're not sure whether they were the ones that smoked occasionally or every day or whatever, but it doesn't matter. Amazingly, 9 of them had stopped over the last 3 months, so that was good. And between baseline and follow-up, there was a statistically significant difference between the number of days that they had reduced their cannabis use. So we were all ecstatic about that and extremely happy. Now we thought, okay, well, these reductions could have been, just because of the passage of time. So then we decided to do something more rigorous, which was to run a randomised controlled trial. And so we did it again, and the objectives now were, can we directly recruit young people without having to go for concerned others? We thought perhaps it's difficult to just get them on their own, and then again assess the feasibility of the ACCU compared to a delayed treatment group. And again, we used MI, and the package was the first session, session 1. We assessed them, we gave them a thorough assessment, which some of you may be familiar with, but obviously this is what we're going to be going through. Assessment, we looked at the severity of dependence, we looked at motivation for change, and so on. And then the second session was to invite the person to come back to get feedback on what they discussed with us the week before. And again, all using MI. So we recruited some young people through drum media. I think we put a very small ad in drum media at the time. And obviously lots has changed these days in terms of social media and how to recruit people these days. Everything's done through the website, Facebook, and so on. But anyway, be that as it may, we recruited some young people. Even though the N was small, we got some still very good and very significant results. And as I said, the randomised controlled trial, you can download it and read all the ins and outs of it. Now, where am I here? Okay, so at baseline, as you can see, there's 74 out of 90 days they smoked, and there was a very good reduction between baseline and follow-up. But between the control group and the treatment group, there was a huge discrepancy. It was quite low for the delayed treatment control group, and that was just an anomaly. I mean, you'd expect them both to be the same at baseline, but it was quite odd that they smoked less than the treatment group. But as you can see, at follow-up, there was absolutely no change in their use, whereas the treatment group, there was change between baseline and follow-up. In terms of the number of cones that they smoked per week, there was a significant reduction in the treatment group, and there was even a reduction in the delayed treatment group. Now, that was interesting enough in itself, and all we can surmise, I guess, is just talking about cannabis for an hour, perhaps, increases awareness. I mean, we didn't say a lot, but yeah, just talking about it perhaps just increases awareness. But then in terms of other measures that we took, as you can see, there was a significant drop or a significant difference between the treatment group, baseline and follow-up. But the delayed treatment group, there was no difference. It was the same, and the percentage of dependent individuals did drop in the treatment group, but did not drop in the delayed treatment control group. So conclusions, basically, some cannabis users will seek treatment without being coerced, and that goes back to what we found, as I said, that 58% had actually tried to reduce or cut down on their own without even having any intervention from anybody. So that was good, and we also found that a 60-minute motivational using MI session entailing assessment and feedback could effectively reduce cannabis use. And so we were quite chuffed about that. Just to give you some stats on young people before we get to the ACCU that I think is important to look at, and this came out of the last national household survey done in 2010, and I believe there's one 2013 that will be available in December. I'm not sure, but off the top of my head, I'm not sure, but I think they pretty much look the same. But have a look if you can at the 2013 household survey. But this looks at ever used, and that is ever in your entire life, and recent use. And recent use looks at the past year. And so, as you can see, the people who most commonly use or recently were between 18 and 29. Again, young people. So I wanted to look at, specifically, young people, and so I got some stats from the Australian secondary school students, 2011, and that's the way it looked. Now, when I added it all up, I found that 85% of kids between 12 and 17 never used, but that meant that 15% did. 15% of kids between 12 and 17 used cannabis. Now, that's if you think that half the population is sort of children or young babies to 12, and you're looking at possibly 1.5 million kids between 12 and 17 that have used cannabis. And when I looked at it more closely and looked at the last week, that's 400,000. That's almost 500,000 kids that have smoked cannabis in the last week. So that's a lot of kids that are exposed to cannabis. And we know that, as I said earlier, it's kind of the quiet achiever. If you sort of start smoking occasionally, then within a very short period of time, particularly if you're young, you will develop a dependency. So, but then again, it is not all doom and gloom. It is absolutely not all doom and gloom, because not everybody that starts smoking cannabis becomes dependent. So that's a good thing, only 1 in 10. As I said, not all doom and gloom, and it's not all, dramatic. But adolescent substance use generally is a complex issue, and I guess just being young, I suggest that, you're a risk taker, you want to do stuff, you want to try stuff, particularly if your peers are doing it. But most who begin do not continue to develop significant issues, which is, as I said, a good thing. And most use is functional. I mean, it's social, it's fun, it's recreational. You do it because your friends do it, and you do it because you want to try something new, and so on. So, using one substance, again, doesn't necessarily mean that you're going to go on to another. But the thing to note really is that it can show rapid changes in pattern and context if you're young to the way you're behaving. And again, without going into detail, it's all about adolescent development and the young brain developing, and it doesn't stop maturing till 24, and it's all about neuronal connections and so on. And so being young, and particularly adolescence, is a very, very important age for brain development. So I just thought I'd kind of, throw that in, just by the by. Okay, so again, going through these hopefully very quickly. Why do some young people use substances? Well, because they can. No, I'm just kidding. Because they do. It usually falls into kind of 4 categories: experimental, occasional, which again is, like I said, it's functional. It's fun, it's there, you just do it. And then harmful, that's risky, because that kind of level of use becomes always attached to some fairly significant risks. And then you can become dependent. Experimental use, as I said, I guess it's being defined by you try a substance for the first time out of curiosity or just for the desire to do something new. Occasional use, the substance has a specific purpose, it's recreational, it's fun, but most of the other functions in your life are intact, and there's really no motivation for you to stop because it doesn't necessarily have any downsides at this particular point. Then we go on to harmful use, where the substance use has specific purposes in an individual's life. It's used for a particular reason. And again, it can be functional, it can be fun, it can be social, it can heighten enjoyment, and so on. And again, some aspects of life are often intact, and perhaps it begins to impact on personal relationships. Problems begin to emerge. They're not necessarily obvious to that person, but it leads to perhaps physical problems, psychological problems, social problems, and so that's what we might define as harmful use. And so, due to the increased problems that start to begin to emerge, an individual may have some motivation to rethink their use and rethink the levels that they're using. So that's a good thing. When some things begin to look as though, it's not so fantastic, and this is a really opportune time to, I guess, intervene when there's a connection between their cannabis use or drug use and possible issues or downsides to it. So that then heightens or highlights harmful use and, intoxication, mode of administration. Now, the most common one is breathing it in, is smoking it. And that really speaks to respiratory problems. And just while I'm on that, what I'd perhaps like to kind of point out when talking to young people about the way they use cannabis, which is to smoke it, that it's very harmful on the lungs. And just to kind of give you, I guess, a point of reference, one joint, or the amount that goes in a joint, is equivalent to 3 cones, smoking 3 cones. or the amount that would go into 3 cones. Obviously, it depends on how big your joint is, but just your average joint is equivalent to smoking 3 cones, which is equivalent to smoking 5 cigarettes, which is equivalent to 3 times more tar and 5 times more carbon monoxide. So it does affect one's lungs, particularly young lungs. So that's kind of just to give you an idea of the harms. And again, it may well be because cannabis is inhaled and the smoke is inhaled deeply into the lungs, therefore perhaps doing more damage. Now, that's not even throwing in the burning of petrochemicals, like through a plastic bong, where you're heating up that plastic and you're inhaling whatever that gives off. So again, it is extremely harmful, and these are the harms that occur due to excessive use of cannabis: intoxication, the mode of administration, depleted support systems because you begin to smoke on your own more often. It does exacerbate other health issues, particularly mental health issues, and obviously the legality of the issue. Dependent use, well, that's what we're trying to avoid. This is the biggest problem because then you begin to feel withdrawal, obviously, and so dependent use is what we are trying to avoid. So the goal really is, the absolute goal for us as healthcare practitioners is to engage with young people early, and our goal is to reduce the risks and to avoid dependence. So if we can intervene as early as we can and get them to at least not increase their use, but hopefully maybe even decrease or even stop their use, then we're definitely ahead of the game. And if we can do that till their brain matures, then we have definitely done something extremely positive. So how do we do all this? We do this through the Adolescent Cannabis Checkup, and as I've already spoken to you about, the feasibility study and the randomised control trial. Now, it's very important that you are familiar with MI because it is the best way to engage young people. And this is what we used when we did the assessment and the feedback. Now, this is the latest edition of Bill Miller's Motivational Interviewing, and as said, I would strongly advise or recommend that you get a hold of this book and read it. And it's hard to read it from cover to cover, but the suggestion I might make would be to read 4, 5, 10 pages and just attempt or digest what that says, and then go back to it again, and then try that, and then go back to it again, and kind of do this over a significant amount of time and see what feels right for you and what seems to work for you, and tweak it as you go along. And if you keep doing this, if you keep trying to dip in and out of the book, which is my suggestion, then after a year you will become extremely proficient at it and feel very comfortable in your understanding and use of MI. But again, this is something that we strongly suggest people try to really get a handle on when they're in the, counselling profession. The key points of MI is to express empathy, develop discrepancy, and that's done. That is done very subtly when using the ACCU. Supporting self-efficacy, and we do this through the use of open-ended questions and reflections and affirmations. And so again, it is very, very important that you are familiar with the use of MI. Alrighty, so learning outcomes. What I'm hoping that the listeners who treat individuals presenting with cannabis use disorder is to introduce them to this very brief and efficacious intervention, and for them to be familiar with the material when they deliver the ACCU to people who present to them with cannabis use disorder. All right, so I hope that by the end of the webinars, by the end of the next couple of weeks, that you will be be more familiar with the intervention, which then increases the chances that you will use it, and so doing, reduce the harms, and then be familiar with the resources. And that's why I suggested that Dion send them to you. There might be, because it might be a bit tricky you downloading them from our website at the moment. And as I said, I hope that you've kind of got a copy in front of you that will kind of quickly go through perhaps today. And I'll send you a filled out copy within the next 2 days. So why are we suggesting that you use the ACCU brief intervention? Well, it's standardised. You don't need to kind of think about anything or organise anything. It's kind of done in a kind of logical sequence. We know that it works, as we've done, as I said, the pilot and the randomised controlled trial. The material is available for you, not just the downloadable material, but also the other resources that go with it that you can order from our website. And all we're trying to do is increase the chances of affecting some change in young people as early as we can. Alrighty, so the ACCU. Now I need to stress that the ACCU is a collaborative conversation. You are exploring the relationship between what they're seeing you about and their cannabis use. So that's what you're doing, is having a conversation. It is not counselling. It is not trying to get them to change. It is a conversation, even though you even though you probably know that they need to stop or that it is interfering with their life, but that's not how it should come across. It should come across simply as a collaborative conversation that you're having with them, as though you're not sure whether this has any, impact on their life, but you just want to discuss it with them. And through doing that, you are drawing out their own reasons for change by simply listening for change talk. And that's what you're listening out for, and that's one of the things that Bill Miller talks about now in his latest book on MI. You're listening out for change talk, and when you hear that change talk, you then support them with a plan that you put into action. So I just want you to note that this is not a tick and a flick kind of assessment. This is not, when, yes, no, every day, sometimes, in that way. It is a conversation that you have. So it's not a tick and a flick. It is not a counselling session. There is no suggestion that they should change. It is a conversation, as I said, that it's collaborative. Now, you need to tell them that, you're going to go through this with them, and that it is just assessing the relationship of cannabis between various aspects of their life, physical, psychological, and social, and that some of the questionnaires they will fill out and some of it you'll fill out. So, it's collaborative, and you will preface your counselling session with them that this is what will happen, because at first glance it looks, oh my God, there's so many pages in here, it's too big, but that is really not the way it's meant to be delivered. So you will tell them that some of it, you'll fill out, and some of it they'll fill out, and therefore you need to check to make sure that they can read. Now, if they can't read, then you will need to read it for them, which might take a little bit longer, but that's, I guess, the downside. Now, over the next 3 webinars, there's going to be a demonstration of some of the content of the assessment and some of the content of the feedback. We've got 8 little vignettes that we filmed to, I guess, so that you can refer to, just to see, them being played out, I guess, in a semi-real situation. So over the next 3 weeks, I'll be showing you those little vignettes. Now, the content of the ACCU, as I said, there are 2 sessions. There's the assessment and the feedback. Now, the thing is, it's an invitation to engage in this process. So because I don't know where you all work and how people come to you, I suspect that there is a generic intake or assessment that you do when someone comes to your service. You know, who are you, how old are you, what are you seeing us about, and doesn't necessarily need to be an alcohol or other drug service. It could be anybody. But suffice it to say, they come to your service, they're assessed, and cannabis is seen as a fairly significant part of their life by you because they've told you that they smoke and they've told you how much they smoke, even though that's not necessarily what they're seeing you about, and you will invite them. Now, it does need to be the primary drug of choice. Now, I do understand that a lot of young people use lots of other drugs, and obviously it's up to you to decide which drug is the most problematic drug and which drug you want to attend to first if you work in a drug and alcohol service. However, because this all relates to cannabis, you would use the ACCU with young people whose primary drug of choice is cannabis, even though they do other things, but this is the one that, according to you, or the one that you consider perhaps is an issue. So you look at that, you will ask how, quantity, frequency, duration, and according to your clinical assessment, think, okay, well, I need to kind of address this cannabis with that young person. So you'll say, look, let's just, for argument's sake, call him Eric, and I will introduce you to Eric very shortly. Eric, look, I'm not really sure whether or not cannabis has anything to do with whatever they're seeing you about, but I'd like to look at this a little bit further with you because it may or it may not have anything to do with what you're seeing me about. Would it be okay if you come back to see me to do what we call a checkup? It's simply, looking at cannabis and cannabis in relation to your physical state of health, your psychological state of health, or any kind of social part of your life. So would it be okay for you to come back and go through this checkup with me just so that I can get a clearer idea as to whether or not cannabis is impacting on your life or on this particular thing that you're seeing me about? So would it be okay for you to come back next week? It takes about an hour to do the assessment, and then there's a feedback session, a week or so later, which takes about another hour. So would it be okay for you to come back and do that with me? It needs to be an invitation. It absolutely needs to be an invitation because they need to be there. I mean, some of them are going to be coerced, that's fine, but again, it's still an invitation to explore cannabis in relation to various aspects of their life, physical, psychological, and social. So I just need to make that very clear, that it's really not for people who have no insight, absolutely happy with their cannabis use, don't even want to engage in a discussion with you about their cannabis use, and so on. I'm not saying you shouldn't try it, but really this is designed for clients who at least want to talk to you about their cannabis use. So it's an invitation to come back and explore their cannabis use a little bit more in depth. And now these are the things that go with the ACCU. These are the things that you will need if you want to deliver the ACCU. And as you can see, the one with the red outline is the first thing, which is the assessment. And then behind that, you can see the personal feedback report. That goes with the little green one down next to the assessment there, the little slimline one. They're the same. They have the same content. The difference is that the report stays with you in your files, and the form, the personal feedback form, is given to the client. But they're both filled out by you after the assessment is done, and then they come back for the feedback session. And then that other book, What's the Deal, is given to them either at the end of the assessment session or in the following week, depending on where they're at in terms of readiness to change. And then the black book, the strategy workbook, is the one that is given to clients who are actually wanting to do something about their cannabis use. And they're given that book and they work through that book with you over the course of a third optional session. It doesn't have to be one. It can be 2, 3, or 4, however many sessions they want to see you. Okay, but in terms of the assessment, the first session you will use the ACCU baseline assessment, which looks like that. Alrighty, so here we go. This is Eric. Meet Eric. Say hello to Eric. I, again, want to stress that adolescence is a period of profound brain maturation, and 75% of mental illness occurs within, or between the ages of 15 to 24. And 90% of substance use begins in adolescence, between the ages of, approximately 12 years of age and 19. So early initiation is linked with progression to heavy use, as I said, and dependence. And then school attainment is a significant factor when you're at school and you start to use cannabis, and then that leads to career opportunities or lack thereof and choices. So adolescent and early adulthood are times of both physical and mental development. It's also a time of great morbidity, which is associated with psychiatric disorders. So we really need to keep that in mind when we're talking to young people and trying to work out what's happening with their brains. All right. So as I said, meet Eric. Oh, hang on. I didn't tell you about Eric. All right. Eric is, and we will be talking about Eric over the next 3 webinars. Eric is, and again, I don't know your client group, but I have to start somewhere, so you need to forgive me if this is not your client group, but I guess I kind of pitched it perhaps to people who were part of our randomised controlled trial, who kind of looked like this a bit. So anyway, this is Eric. He's a 23-year-old male. He's a carpenter who still lives at home. It took him 5 years to finish his certificate and finally become a fully fledged carpenter. He's been employed for the last 2 years, and he does have a girlfriend. They've been together for about 18 months. Now, he smokes on average about 8 cones a day, 2 in the morning, 2 after work, and the rest over the course of the evening. He tends to smoke more on a weekend than he does during the week. He also smokes a little bit more when he gets paid and so on, depending on where he's going, concerts and so on. But generally speaking, he smokes about 8 cones a day, give or take. Now, he's always having drama about his smoking with his parents and his girlfriend. Always drama around that. There are other downsides, but the one that, he's most concerned about is the drama he has with his parents and girlfriends. Now, he presented, again, this is a fictitious person, but I tried to make it as close to real life as I possibly could. Again, bearing in mind that not all your clients will look like this. So the presentation, court diversion. He was picked up, poor guy, on a random roadside testing, pulled aside randomly, got DUI'd, was very unlucky. He had been drinking on the way home, but because he was also stoned, he was driving very, very slowly, thinking that he'd be okay. But never mind, needless to say, the policeman was not very impressed, so he decided to take him down to the police station. He got blood tested because the policeman wanted to check for other drugs, given his age, and he tested positive for cannabis. That was seriously bad luck for Eric. Doesn't normally drink and doesn't normally drink and drive, but there you go. As they say, S-H-I-T happens. So that is Eric. Eric was sent to see someone because through court diversion or merit program or whatever happens to be in your state, and comes to see, let's say, me, and I go, okay, so what brings you here? Well, I had to be here. Court sent me. blah, blah. I go, okay, well, I've got what we refer to as the cannabis checkup. I don't know, maybe this was bad luck, maybe this was a one-off, but for me to kind of look at this in a little bit more detail and perhaps write a court report or do the right thing by you, I think it would be great for us to do this checkup. As I said, I don't know whether it's a problem for you or not, but would it be okay for us to go through this cannabis checkup together? So, yeah, doesn't have much of a choice really. So this is the content of the ACCU. These are the main headings. And as I said, we will go through its content. And as I said 5 slides ago, it is not a tick and a flick. It is a conversation that I will be having with Eric over the next, or I would say 2 sessions, but for us, 3 webinars. And I will send you the filled out version of the ACCU as though it were Eric, and I'd fill it out as though it was Eric for us to talk about so that we're all on the same page over the next 3 webinars. So I hope that's okay with you, that we use Eric as a case study. Now, as you can see, these are the main headings: presenting reasons for quitting or concerns. Now, if you've got it in front of you, you'll see it that way. And then the bottom of that page is the readiness to change. So that's what making changes is about. This is the readiness to change part. And then we look at the decisional balance. What are the good things and the not so good things about using cannabis? Then we look in detail about pattern of use. You know, when do you use? What time do you use? Who do you use with? Again, as I said, you don't ask it in that way. You just say, look, can we just talk about, you know, your general pattern of cannabis use? Can you tell me a bit more about that? And that's the way it's kind of presented. You will ask when he first started, when did you become a daily smoker, and so on. And then the TLFB stands for timeline followback, which is a little it's a little calendar. It's like a little diary of how much he used. And I know their memory isn't the best, but they can pretty much kind of remember the last 30 days. And there are anchor points that you'll ask. You know, do you smoke more on a weekend than you do during the week? Do you smoke more when you get paid than when you don't pay? Okay, over the last 4 weeks. And even though on your assessment there's actually 60 days there, you don't have to do the whole 60 days. 30 days is more than enough for you to get a really good idea of their pattern. And so okay, do you smoke more on weekend than during the week, when you get paid? Has there been any time over the last 4 weeks or weekends where you've gone out, you've had a party, gone to a concert, done anything out of the blue, and so on? And in that case, you will get a really clear picture that it is not 8 every day exactly, that on some days it's 12, on other days it may be 15, on a weekend it may be 10, and so on. Now, I just also want to point out that the timeline followback has been done in and of itself as an intervention and has been found to reduce cannabis use when it's just done by itself, because people reflect on what they've used over the last 30 days. And again, we found that there was a reduction just doing the timeline followback alone. So that's what the TLFB stands for. And then you talk about how much money you spend. Have you tried to quit or reduce? What's that history like? Do you use other drugs? Maybe you've already got that information, but you'll just review it again. And then you might ask some questions about risk perception. Do you know what I mean when I use the term risk? Can you give me an example of what risk means? There are some questions here that involve, you know, whether or not you'd make a decision about whether you want to continue or reduce related to some risks. And so that's what that question's about, which we'll look at a bit more closely. Then there's the SDS, the severity of dependence scale. Now, some of you may be fully familiar with it, but that's part of the assessment. So you would ask about the severity of dependence. Again, we'll talk more about that on Wednesday as to the preamble, how you would introduce it, how you would plant a seed about it being a drug of dependence, and so on. But that's what the SDS is. And then there's a questionnaire about the expected costs and benefits of using and the expected costs and benefits of increasing or decreasing one's use. And then there's the problems questionnaire in and of itself, which I think is really good, a really good prompt in someone's mind about the issues that may be related or problems related to cannabis. Even though, may I say at this point, you do not discuss it as problems. You never use the word problems in conversation. Cannabis is not a problem. All you're doing is exploring the relationship between their cannabis use and whatever issue they're seeing you about. And when you talk about problems, you talk about other people having problems. You know, these are problems that other people have. And I want to know whether or not you think that it may, you know, have anything to do with you, for example, in the future. So that's kind of how it's couched. And then we go on to looking at health under the kind of heading of possible problems, physical and psychological, social and legal. So the next couple of pages are all related to looking at those sorts of things with Eric. And then we look at some goals and aspirations. We project forward. You know, how does the future look now? You're 23, Eric. I want you to imagine that you're 26. What are some things that you'd like to have achieved or, you know, want to have? And you look at those things in relation to cannabis use. And then you look at some relationships that mean a lot to him, some people who he respects and whose advice he would respect, and so on. So you look at the relationships that are currently in that person's life and how those people feel about his cannabis use and so on. And then the last questions are about immediate goals. You know, how interested, how important is it? How interested is he about reducing right now, in general, in the future? How interested, how confident would Eric be? And so that is basically the content of the ACCU. Right, now where are we? We've got 5 minutes to go, I guess. So I might just start with Eric. As I said, he came last week. He got done DUI. I invited him to come back. He really didn't have much of a choice. And so I would start with, oh, hi, Eric. How are you? How have you been? How are things? And so on. Now, look, this is the ACCU. Everything that you say to me is confidential. I will be writing a report, but at the moment, anything that you and I talk about is confidential. But you don't need to answer anything if you don't feel comfortable with it. That's okay. And as I said, some of this you'll fill out and some of it I'll fill out. Is that okay with you? Yep, no problem. So name, date of when you saw them. So tell me, what is the main reason that you've decided to come back? Because you don't have to. You can breach the court order if you wanted to, but you have decided to come back. So what's the main reason that you've come back and decided to do this with me? And his answer might be something like, well, I didn't really have a choice. I mean, you know, I don't want to get into more trouble. I had to. But, you know, I'm also a bit curious about what you'd say about cannabis or dope or weed or whatever they call it. That's the other thing. You need to refer to it in exactly the way that they refer to it, and perhaps just somewhere along the line suggest that its proper name is cannabis. However, you will refer to it as they do. So, yeah, he might be a bit curious about, you know, about mull, weed, pot, and that's the other thing that that's the other reason that he's come back. Are there any other reasons for wanting to come back to do this checkup with me, Eric? No, I'm happy. Okay, well, the following is some statements about, where cannabis fits in with you today or in the future. Can you just read these statements and, tell me which one best represents how you feel about your cannabis use right now? So there's 4 statements there. So tick the one that you think best represents how you're feeling about it. Now, if they have ticked the first one, well, I guess there's been a disconnect somewhere and they're really not interested in discussing it at all. But then again, that is your clinical judgment and you can decide whether or not you want to continue with this. Usually, they will tick the next box, which is, oh, look, been thinking about it, but really I'm not prepared to do it right now. Yeah, it's got me into a bit of trouble, but, at the end of the day, it's really no big deal. So, yeah, maybe I should one day, but certainly not within the next 30 days. So that is generally the people who this is most suited for. And then the next page is looking at that's readiness to change. And then the next one is where just to get started, I'd just like you to tell me some of the good things that you like about cannabis use. Like, what are some, you can call it what you like. You can either call it good things or benefits or whatever. But, you're starting off with the positives of their cannabis use. So that kind of makes them feel, less vulnerable. And it's a really good way to start with talking about the good things so that they're not so defensive. And validating those, because obviously there are reasons. There are, according to them, good reasons why they use cannabis. And so that's where you would start. And then, of course, you would say, okay, well, the flip side, is there anything that's not so good about using cannabis? And I'm sure that you're all familiar with the decisional balance and how to do that. That's the decisional balance, which looks at the good things and the not so good things about cannabis. And then you would start looking at patterns.
All right. Thank you, Etty, and thank you, everyone, for attending.